Okay. And I want to welcome our audience. I am Rebecca Berman. Can't even say my own name, Rebecca Berman, our moderator for today, and Glenn's sister. We are thrilled to have you all with us here today, and those watching on YouTube after the taping. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the US and outside of the US. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So we have a lot of great questions that came in during the week. Thank you for those who sent them in. If you have a question that comes up during our session, just send it to me privately via the chat at the bottom. Glenn has been with us. I've lost track of how many weeks, months we've been doing this, but you have provided so much valuable advice. And I'm proud to say I finally just received my pulse oximeter that you told us to get a few weeks ago. So now we are good to go. So if you have not yet ordered, I don't know what brand, it doesn't really matter, but you should go ahead and do that. If you are not on mute, we ask that you please press mute on your microphone so that we don't have feedback. Or Glenn, maybe you want to
mute. Unmute. Beck, you're on mute. Can you unmute yourself?
There we go. So without further ado, we have our host, Glenn Grossman. Take it away.
Great. Thank you, Becky. All right. So I am opening up this. So welcome, everybody. I'm going to share my screen. So we were talking last week about maybe pushing this up because now we're in the summer months. So we're thinking about maybe starting this at 7 o'clock on Sundays going forward through the summer. So hopefully that's okay for most people. I did a brief poll and that seemed like it was better. And if you miss it at 7 o'clock on Sunday nights, then you can catch it on YouTube throughout the week. But all right, Beck, so why don't you start? Let's see what the first question is.
So let's start off by talking about New York. Many of us are here in New York. We've got guests in Florida and around the country. But let's start off by talking about New York. Did New York lock down quickly enough is the question. Should they have locked down sooner? Why was New York hit so much harder than Florida?
Good question. So here we go. All right, so here's the graphs of New York. If you'll notice that the x-axis, or rather the y-axis is a little bit on a different scale. So 1,000 is here for Florida, whereas 10,000 is here. So it's not exactly the same scale. I tried to make it a little bit bigger so you could see. But anyway, you can see a couple interesting things. First of all, New York was hit far harder than Florida was. But in terms of when New York went under lockdown, there's a couple interesting things. So it looks like New York went under lockdown approximately March 20th is when the order was put in place. And Florida didn't have their lockdown order until approximately April 2nd or April 3rd. I'm not sure the exact dates here, but just order of magnitude, just on the graph, what it looks like. Interestingly, New York shut down around 5 days after it hit 500 new daily diagnosed cases. But Florida didn't shut down until 10 days after it hit 500 daily new cases. And so if you were using a metric, like if you remember a couple months ago, we didn't really know what was going on. We didn't really know what the R value was. We didn't know if it would differ by state. And so it was very haphazard. Usually in all the planning that had been done for the last 5 or 10 years in previous administrations, there was this assumption that the US CDC at the federal government would tell each of the states what to do and there would be some guidance and some leadership. But because there was no leadership and it was all pushed to the states, the states didn't really know what to do, and so they all had different approaches. So there were 50 different approaches across the 50 states. And so what you see here is that if you use an indicator of hitting 500 new daily diagnosed cases, then New York actually shut down much quicker after it hit that threshold than Florida did. So they shut down 5 days after hitting around 500, whereas Florida was around 10 days after hitting 500. But what you'll notice here is that the R value was way higher in New York. They couldn't have known this at the time, but it turns out on reflection that R was equal to 5 in New York based on the revealed curve of the cases that actually became diagnosed in retrospect, whereas Florida's R value was around 3. And so because of this, the number of new cases were multiplying far more quickly in New York than they were in Florida. A couple reasons for that, or a bunch of different reasons for that. One of them being the population density, another one being the it could have been the weather. I mean, there's a lot of things that could have been going on in that place. But there were different reasons for why the R was bigger. But what you'll notice here is that New York, with the order in place, dropped from an R equals 5 down to below 1. So now they're at R is 0.7. The last time I checked, and so that means that even without therapies or vaccines, they're still reducing the epidemic in New York. In Florida was at a peak of 3, but you'll notice in the most recent data, they never went below an R of around 1. And so there were still new cases that were occurring every day. You'll see that in the last few days, there's starting to be what looks like an uptick in the new cases, whereas New York does not exhibit this uptick yet. And so it's still very early. The cases that we started seeing over the last few days were new symptoms generally from people who were infected around Memorial Day weekend. So there's a delay of maybe a week or two between when people are first infected and start getting symptoms, and then there's another delay between when they start getting symptoms and are hospitalized, and then there's another delay between when they're hospitalized and some of them die. And so you'll see a long delay. It could be 2-3 weeks or more until you start seeing this bigger delay. In fact, what you'll notice here is when the lockdown was put in place in New York, it was several weeks that went by before we hit the peak in terms of the transmission. So you don't see the effect of things for a period of time. And so that's just something. So in terms of whether New York had better policies in place than Florida, obviously they should have gone under lockdown sooner, but at the time, it's not clear that they could have known, because look, Florida didn't go into lockdown until later, and Florida did not nearly as poorly as New York in terms of the order of magnitude of number of critically ill and people dying. So anyway, that's that comparison.
That's helpful. Thank you, Glenn. So now that most states have come out of lockdown, what are you seeing? Are most people staying at home, or have we returned to where we were before the pandemic, or where are we in between those extremes? What are we seeing? I know some companies have been using kind of cell phone data to tell us how people are moving. How do you get your data, and what do you deduce?
Yeah, so this is the latest that I was able to find in terms of transmission. This is using cell phone data. I believe that this is using, give me 1 second. Oops. So this is coming from the Washington Post. On the upper left-hand corner, this was the amount of cell phone travel before the lockdowns. And then what you'll see on the right is this was the amount of travel right in the middle of the lockdowns. So you see a huge difference between the lockdown on the right versus not the lockdown. And what we're seeing, this was May 24th data. So this is still, it's a lot more open now than it was May 24th, because this was before Memorial Day. But still, this was a lot of the lockdowns had started lifting by this point. And you'll notice that there was a lot more activity, a lot more travel during this time. And there were some studies done, I think I discussed one of them last week, at the correlation between people's willingness to leave their house and travel around and their willingness to not wear a mask and not be socially distant when they're with other people. And so even though some people are being responsible and are traveling, but then are still wearing masks, and when they get to their destination are still separating themselves, there's a lot more people who are not separating themselves and are traveling and are not wearing masks. And so we are, this does explain part of the uptake. So last week I mentioned that there were approximately 140,000, a little bit more than 140,000 new cases in the week before. When we look back at this past week, there were 153,000 new diagnosed cases, all new diagnosed. And so this is an uptick. It's not a lot. It's not like we have twice as many as the week before, but it is more than it was. In fact, when you look at the numbers, the last date that we had was June 5th. So from Friday, the number of new diagnosed cases hadn't been that high since May 16th. So a few weeks ago. And it was only that high around in under 20 times over the last 3 months has it been so high as it was on Friday, this past Friday. So the numbers do seem like they're starting to go up. Again, this uptick that we're seeing is mostly still Memorial Day weekend stuff that we're starting to see. It's too soon to really be seeing any uptick due to the protests that came after that.
So where are the new hotspots that we're seeing in this uptick?
So it's interesting that, so we're generally seeing reduced rates in the Northeast. The Northeast got hit really hard at first. And so they were later to come under lockdown, but because of the severity of how hard they were hit, they tended to respond pretty well, with the exception of Maine. Maine wasn't hit as hard as the New York City or Boston metro areas, but it's now not responding quite as well as the rest of the Northeast is. And similarly, when you look at the South and the West, they're tending to be the hotspots right now. There's a bunch of countries that are not doing very well. In fact, when you look specifically, the key ones that I'm keeping an eye on this week are Arizona, Arkansas, North Carolina, and Maine. Although you'll see in general that the West and the South in general are hotspots that we need to keep an eye on. And so that's where things are really growing. So there's sort of this epidemiologic shift in the country based on geography in terms of what's going on and where things are erupting. Also interesting, so I pulled those out. Utah was also one that I saw as an interesting one. So this is if you look at just the West. One way of looking at this is not necessarily looking at diagnosed cases, because the number of tests we've been doing has been going up. So some of that increase could simply be due to more tests, but hospitalization rates are not the same, because people who are sick enough to be hospitalized differentiate themselves. So it's not just a test where you could be getting more asymptomatic people. These hospitalized people are symptomatic and critically ill enough to be going to the hospital.
And so we have some questions coming in. You know, why are we seeing these hotspots? Are these the first states that opened? Another question is, are states still catching up with testing? Do they now have adequate or improved testing this week over last? I mean, can you tell us any trends why these particular states or regions are hotspots?
Sure, let me share my other screen. So when you look at some of them that we've just reviewed, so Arizona, for instance, they didn't have a lot, and this is interesting, it seems pretty consistent. I haven't looked to see if it's universally true, but it seems like the states that were hit harder are more constrained now. And so both the population as well as the policies are reflecting this concern. So that even when we're opening up, it's much more restricted. People are not traveling as much in the states where we were harder hit. A state like Arizona is the opposite. And that's what we're looking at in the South and the Midwest, which were not as hard hit as the others, or not the Midwest, rather the West. Parts of the West were not as hard hit. And so Arizona, which is in the West, at first it wasn't very hard hit. And because of that, you can see that the number of infections were still increasing even before they were reopening, but the numbers weren't huge. It was a small number of new infections. But then when they reopened, the population just started going back to normal almost. And so now the numbers are starting to go up. And I think this is part of the explanation that we're seeing in a lot of the states that are now opening up and we're seeing more hotspots, is that you have this history where there just weren't a lot of infections. Maybe people didn't know other people personally who were infected, whereas in the New York City metro area and other large areas, we knew people who were personally were hospitalized or who died from COVID-19. And so it wasn't an abstract idea. I think for people who live in Arizona, for a lot of them, it's still a very abstract idea. And so it's easy to think that it was overblown by the news or there was something else going on. And so I think that's driving a lot of the behavior that we're seeing. So let's see what Utah looks like. So here's Utah. Also, it was not as hard hit early on, and now it's starting to have an uptick. But yeah, it's in terms of, here's another website that's interesting. So in terms of the South, the test positives so Arizona is another one where the test positives are increasing. Remember, in past weeks, I had said the test positive rate can indicate two things. It can indicate if more people are getting positive, then you have a higher test positive rate. And that assumes if the number of tests are the same. Alternatively, if you're increasing the number of tests, then you want that number to be below, let's say 5% or lower, because then that reflects that you're not just testing symptomatic people, but you're also testing asymptomatic people. So you can identify people who might be transmitting the virus but don't have symptoms before they spread the chain of infections to other people. In Arizona, at 11.3% test positive rate, which is increasing, suggests both. It suggests, one, that it's probably mostly just the symptomatic people that are getting tested, which is bad because then the asymptomatic people can be spreading it without any constraint. And then two, the fact that it's increasing demonstrates that there's spread that we saw in those other graphs. So in some places it's increasing or decreasing, and this is pretty consistent. Massachusetts isn't doing well. They're slightly increasing in terms of what their numbers are looking like, which is consistent with the other graph that I was mentioning earlier. But so yeah, there is quite a lot of variation around the country there. All right.
So what does this tell us about social distancing? Is social distancing worth it? Why is this happening? Are people wearing masks? Is it effective to wear a mask? What is going on?
Yeah, so this is a really good question. And so we've assumed that social distancing is beneficial. It makes sense because if it's a virus and the virus transmits, presumably it's respiratory transmission, then the further you away, if you stop yourself from being exposed, then it should help. But we didn't know how effective it was. So now there's been some meta-analyses that have come out that are demonstrating we have a much, much better idea of really how effective it is. And so now we know this was done in meters because most of the rest of the world uses meters. In the United States, we use feet. So I converted from meters to feet here for us. But so generally outdoors, people, if you are 3.3 feet away from someone, then it reduces your risk of transmission or of getting infected by 82%. And then each additional 3.3 feet, so I know it's a little bit odd, but that's approximately 1 meter, reduces it an additional 50%. So 6 feet that we've been talking about, 6 feet social distancing reduces it by 89%. You'll notice it's not reduced by 100% when you reduce it by 6 feet. It reduces it by 89%. That's a big help, but that does not mean we're perfectly safe. At 10 feet away, it reduces it by 95%. So if we're gonna go outside and picnic, which a lot of us have been doing, and I recommend it, we need to get out of the house and we need to socialize more, but to be safer, consider if you're picnicking outside that you sit 10 feet away. And that might be a little bit better, particularly if you're a higher risk household, either with higher age or comorbidities or other things that might increase your risk. And then interestingly, so in terms of the social distancing portion, so now this is the best data that we have. There have been polls that have been going on in terms of whether people believe personally that social distancing is worth it. And only around 3/4 of people in the United States believe that social distancing is worth it. And so this varies based on support of it's become very polarized politically, and which is unfortunate. But interestingly, this in some of the spread that we might be looking at corresponds in some ways with the geography that we're looking at as well, in terms of blue states versus red states, where if you believe that social distancing's important, then you're way more likely to socially distance yourself. Whereas if you don't believe that social distancing is important, then you don't do it as much. And to the degree that social distancing contributes to spread or reduction in spread, then this is something that could have an impact. If we had stronger leadership at the top saying we need to social distance, then that would push the number up. But right now you can see the fact that there's this polarization in terms of people's perception of the science, because the science is clear now. So in terms of people's perception of the science, that comes from communication. There's a communication breakdown.
Interesting.
Did you ask about a mask
Yeah.
also, or
So,
was that
yeah, I was asking about masks. So
Right.
that's really good information about social distancing. But in addition, tell us about wearing a mask.
So yeah, we've talked about masks before. New data has come in to show exactly or relatively how helpful wearing a mask is. You see that there's a range. We've seen graphs like this before. Let me see if I can make it a little bit bigger. So this is called a forest plot in epidemiology. Basically what you're looking at is among all, is it harder to see or easier to see this way? There. So this is looking at lots of studies, and it looks at the averages. So what you need to look at are these diamonds, which are the averages across different things. This group of studies are in healthcare settings, and this group of studies are in non-healthcare settings. So all of us, or most of us watching, are going to be in non-healthcare settings. And so you'll see that the diamond, so a relative risk of 1 means that there's no benefit for wearing masks, that the risk of transmission, whether you wear a mask or don't, would be the same. Anything less than 1 demonstrates a reduced likelihood, reduced risk of transmission. And so you see that in the hospital setting, it goes to 0.3, which is a huge reduction in risk versus 1. In a non-healthcare setting, when people are just going out and wearing masks around, the reduction in risk is important. It's 0.56, but it's not as important, not as large as in a healthcare setting, largely because a lot of people are wearing their masks wrong. The one thing you need to remember is that a mask is not a SARS-CoV-2 magnet. The SARS-CoV-2 is an invisible, under a microscope you can see it, but to the visible eye, it's invisible, and it can just goes through the air. And so for the mask to be effective, all of the air needs to come through the mask. If any air is coming through the sides, then you're not protecting yourself. There is a little bit of protection, but it's not as strong a protection as people in a healthcare settings who are using their masks correctly. If the masks have a little bit of space, then what's happening is that you're probably just redirecting the air away. So whoever you're talking to directly won't be exposed, but by redirecting it, you are preventing the person directly in front of you from getting it. But if there's people behind you or to the side, then you might be shooting the air at them, and so that wouldn't be as helpful. All right, let's see. Next.
Glenn, can I ask you some more questions about this mask? I mean, let's demonstrate. So I have this mask.
Yeah.
Okay, we'll use props.
Give me 1 second. Give me 1 second to stop sharing so I can see your face.
Okay, so here I am. So I have this one, and it's actually really cool. I can make it nice and tight. There are these little pieces at the end, so it can be like around my face, nice and tight. Now, it's 2 layers of fabric, and then it comes with this filter piece. And you can't breathe when you're wearing it with the filter. So can we just wear these 2 layered masks and feel confident that we are protecting others? Because as we know, the reason for the mask is to prevent transmission, whether, you know, we may be asymptomatic and not realize we have it, even if we're completely healthy. Can we just wear these 2-layer cloth masks, wash them, and continue on with the new one every day kind of thing? Or do we have to do this whole filtration process? What do you recommend?
So so there's different risk tolerance and different risk ways of moderating the risk and reducing the risk. Give me 1 second to return. So basically, so yes, there is some protection from having any covering over your face at all. Simply covering your face, even if it's just a cloth mask, a homemade mask, is better than nothing. And, you know, frankly, I believe that people who wear a mask in general, it's almost social signaling that they care about other people. And so that might represent that they're doing other behaviors in general to protect themselves and to protect those around them. And so then maybe it's not just the mask, but it's the body of behaviors that they're doing that would be protective. But the mask itself, there is some evidence that even any covering at all is protective. Having said that, you can see, so based on, if I go back here to what we were just showing, which was here. So the people who wear the most advanced filtration systems and the thicker masks and the ones where there's less virus that can go through, they're more effective. I mean, in a healthcare setting, people might change the masks more. They know how to use the masks because they're wearing it regularly. So it is more effective there, without a doubt. The closer you get to wearing your mask like a healthcare setting person would, a healthcare worker would, the more effective it will be. The less constrained you are, then the less effective it is. But you know, it's hard for months asking people to wear masks out in public and throughout their lives when they're going out around town and doing shopping and doing whatever they're doing, to wear masks as if they're in a healthcare setting is probably unreasonable. And so therefore just wearing any mask at all is better than nothing, and most likely will be somewhere in between.
Okay, so that's helpful. But then now as we move to the next piece, where certainly picnicking is terrific and we love doing that, and we are allowed to eat outside restaurants, and restaurants now are opening at 50% capacity in different places. And so in order to eat, one needs to remove his or her mask, right? So when can we get back? When can we feel really good and safe about going back into restaurants?
That is a great question. And so there's not a lot of data on this, but there was one interesting study. So let me share this with you. So this was done in Wuhan, China, during their outbreak. And what was great about Wuhan, China, was that they had really, really superb contact tracing. It was one of the reasons, in addition to their lockdown, to their quarantine, which was more severe than our lockdown here, one of the benefits is that they could trace really well. And so they had a situation where this was a restaurant. These are all different tables in the restaurant. On January 24th, a pre-symptomatic person ate lunch at this restaurant with their family. They were at table A. And this person, again, had no symptoms when they had lunch. They developed symptoms later in the day, so coughing and a slight fever, but at the time that they had lunch, they had no fever and no symptoms. The distance between tables was approximately 3 feet, and the diameter of the table was approximately 7.5 feet. All right. Each table, when they sat down and ate at the restaurant, they sat there for around 1 to 1.5 hours each. And so one thing we do know is that the length of time of exposure plays a huge role. It's not dichotomous. So what that means is it's not either yes or no, that you're exposed and infected versus no. There's a range. So if you're around someone and you're exposed for just seconds, then your risk is far, far, far lower than if you're around that person for a day, let's say, and you live with that person, or even if you're around them for a couple of hours. The length of time makes an enormous difference that you're around these people. So this person who was asymptomatic at the time, or pre-symptomatic, let's call them, they were in there, and typically the people who ate at this restaurant were in there for like an hour to an hour and a half each. In this restaurant, there were 83 customers, including 8 waiters and staff. So maybe it was less. Let's say around 83 customers, and I don't remember if that was 83 total or the 8 waiters and staff were excess. I think it was 83 total. Because of great contact tracing, everyone after this person was diagnosed and went to the hospital, very quickly they reached out to everyone else and contacted all 83 of those people and had them quarantined in place. So given this information that I just told you, was anyone else infected? So what would you think? Would you say yes or no? I'm giving the example, so yes, I think most heads are probably shaking.
I think we should do a poll.
Okay, I think that's a good idea. Or we can let me stop sharing. We can look at people's, just shake your head, yes or no. Do you think people were infected? Yes, all right, everyone's saying
you can raise your hands, or we're just gonna shake our heads. Okay.
Just shaking your heads is fine. All right. All right, so now let me do the reveal. Let's see. All right, so this was, okay, so again, this one person sitting over here, and remember, this was in a restaurant, so this is probably pretty similar to what we'd be expecting when we start to go back to restaurants. The distances are not super close. 3.3 feet between tables. The table diameter was 7.5 feet, and here are the people that were infected. From this one person, all of these other people were believed to have been infected from this one person. And the reason was that the air conditioner was blowing the wind this way, and then they believe went into the exhaust, recirculated, and then was blown out again to these other people at this other table. There were no people at these other tables or anywhere else in the restaurant who were infected. And so just based on probability alone, it's unlikely that just these people would be infected, and not even a single other person at any of these tables were infected, just based on the prevalence of the disease in the local area, or the virus in the local area. There could be other explanations. So for instance, maybe one person was infected, and then some of these other, like on February 1st, and then maybe they infected these other 2 people. But the fact that these people were infected earlier, then that means that it must have gone through the entire system to get there, is the likely explanation. So that means that indoors, so there's an enormous, I can't stress this enough, enormous difference between socializing outdoors with social distancing versus indoors. And so for people who are at higher risk, so who are older, have other health concerns, maybe racial minorities, other issues, I would not go and sit in indoor seating in a restaurant until we either have really good treatments that are available, wide vaccination, so it's not just you vaccinated, but that the general population is widely vaccinated, and that the number of new cases in your geography have really dropped very low. So I wouldn't sit inside for a while. I know that in a lot of areas, at least in New Jersey, it seems like some areas at least are starting to close down the roads in front of restaurants and then putting tables outside for outside seating so people can go and eat at the restaurants, but just eat outside with enough social distancing. That is probably fine if you're far enough from people, but I would not go, for most people, I would not go inside. The risk just doesn't justify it anytime soon. So I'm talking about months, maybe not for another year or two. But if restaurants can find ways to put their tables outside on sidewalks, maybe closing down the streets, then that would be fantastic. Because like I said, what we just saw earlier is that we do see from social distancing that has an enormous impact on reducing risk. But seeing charts like this concerns me. It's hard to replicate studies like this because our contact tracing is not very good in the United States. And so it would just be very difficult to replicate this. So there is uncertainty about this, but better to be safe than sorry.
Well, that's definitely great advice. However, I'm wondering if anybody else on this call is feeling really tired of cooking. And so I think this is fantastic advice, and I'm sure many of us will heed your advice. Glenn, can you share more about your thoughts on takeout and delivery and how safe you feel that is, and if this is something that you recommend and where we are with that?
Yeah, so that is a really good question, and I haven't prepared a good answer for that. But so the risk would be with takeout if the people who prepare the food were sick and spreading the disease. So whether they were symptomatic or asymptomatic, if they were spreading, could spread the virus. I believe that the likelihood is very, very low. What we do know is that some meat processing plants where people are preparing food in terms of the meat processing plants, people there tend to be very close together, and you see a lot of spread of infections in those areas. But there's no suggestion yet that I've seen that people who are consuming meat products are at any more risk of getting infected than people who are not consuming meat products. And so therefore, with restaurants, I wouldn't believe that if you get takeout, that would be a major risk. So as far as I know, I'll take a look and get back to you next week. But as far as I know right now, getting takeout is a very healthy alternative. As long as you order healthy food, but it's much better than in restaurant dining. And everyone needs to take a break from cooking sometimes, and so it is totally legitimate to get your food delivered. Typically, I know I've been getting a lot of food delivered, and typically what they do is they'll just leave the food outside, and then they'll leave. So all you have to do is open your door, and they're not even there. So the risk is very, very low. With one exception. So one thing that we do know now is that there's been this open question about whether there is active virus in feces. So whether there's viable virus in feces, and now we have evidence that there is. And so most restaurants practice safe or have safe practices in terms of hand washing and this kind of stuff. We know in some restaurants historically, hepatitis A, other types of viruses can spread if people have poor hygiene and they go to the bathroom and they don't wash their hands 100%. And so assuming that they are maintaining the best hygiene practices that they were before, then it's very, very, very unlikely. And so, but is there a possible risk there? Yes, there is a possible risk there. But I would say the risk is extremely low, and it is a safe choice. So say you wanted to go and have a picnic outside and you wanted the food delivered so you didn't have to cook it, and you just went and ate outside with your friends with this delivered food, I think that this is a very safe alternative.
And then assuming that people put their masks on when they wipe the ketchup off of their face, the mask goes back on, right?
Yeah, but you know, this number I showed you even before, not this one. This one, in terms of the reduction of how effective is social distancing, this assumes no mask. So if you're sitting 10 feet away, then even not wearing a mask means you're 95% protected. So wearing the mask might give you this little extra edge, which is useful, but if you're 10 feet away, then even without the mask is not the worst thing in the world, frankly. With the mask, it helps, but you don't have to be so concerned if you're 10 feet away in an open area, sitting on the ground or sitting on whatever. The social distancing outside makes an enormous difference. So the mask helps a little bit with that remaining residual risk, but otherwise it's not an enormous difference for if you're already 10 feet away.
Okay, good to know. Very helpful. So glad to know we can at least continue with our takeout. Otherwise, starvation. Debbie, I agree with you. Your comment would definitely be an issue here. So can we switch gears for a moment and just kind of zoom out? Every Friday night, I get a call. Our mayor does this robocall in town, and he talks about the number of cases, and he talks about where those cases are, but then he kind of segments out the nursing homes and general population. And the numbers in the nursing homes are off the charts, whereas the numbers in general population are not. And certainly, of course, sadly, so are the deaths. So can't we just quarantine the nursing homes so the rest of the economy can get going again? Or what's your take on that?
That is a good question. So let me share my screen again. Here. All right, so one thing you may have noticed or read about in the news, if I can find my slide, is this one. Oh, nope, that's not it. Is this one. All right, give me 1 second. All right, so long-term care facilities. What you'll notice is that the deaths in long-term care facilities represent around 1/3 of all the deaths coming from COVID-19. And this makes sense because age is one of the most important risk factors for critical illness or death from COVID-19. And so you see wide variation across the country in terms of, when you look at the states, in terms of what proportion of people in their state who died from COVID-19, what proportion of them died in long-term care facilities or these nursing homes and other long-term care facilities. And you'll notice that it's enormous. Like New Jersey, around 50% occurred in long-term care facilities. In Virginia, 58%. In Minnesota, 80%. West Virginia, again, 80%. The key thing here, though, in New York, it was 20%, but there might be some error in their reporting. So I'm not quite sure if that's an accurate number or not. But the key takeaway here is that it's quite large. The average for the United States is around 35%. But interestingly, these infections and these deaths occurred when the US was under lockdown for the most part. And so these facilities were under lockdown for the most part. And so these people were infected and all these deaths occurred despite our best attempts for lockdown. And this is not just in the United States. This is something we're seeing globally. The problem is, even under lockdown, you have a lot of people coming and going, as makes sense. You have the nurses who are coming and going. You have the physicians who are coming and going. You have all the staff coming and going. And even if the risk is very, very, very low for each individual person, when you multiply this times all of the people coming and going every single day, and all of those people who might have been exposed to, then you're rolling the dice many, many, many times. And so even if the underlying prevalence or the rate of the disease is very low in the population around you, as it increases, you're increasing the chances. It's like rolling a die and rolling the dice multiple times. And so this number of infections and deaths was despite our best efforts already. There's not much more we can do to lock down these long-term care facilities. And one of the reasons that we have lockdown for everyone was to prevent long-term care deaths. And so when there are less deaths generally in the population, then it's like we're rolling the dice less. And so that means that people who can't protect themselves are protected because of the good lockdown behavior, and social distancing of the general population. But as cases start to rise again, then again, it's rolling the dice more and more, and we're going to see more long-term care impacted. And there's not really any good way to prevent that. We can try our best. We could probably do better than we have been doing, but this is something we're seeing all over the world. Despite the best efforts, it's really hard to prevent exposure, because once you get one in a facility like this, it just spreads like wild, and it's hard to then stop it from spreading throughout the whole facility, because it's inside, it's the air circulating inside, and it's very hard to stop it from spreading.
Thank you. This is really helpful in understanding that kind of question. Can you talk about medical geography? This is a term that's been coming up. You're showing us what's happening all around the world, and particularly here all around the country. And can you tell us what the role of medical geography is part of epidemiology, and what does medical geography tell us about COVID-19?
I thought you would never ask. So first of all, medical geography is sort of a related field to epidemiology. It sits within the field of geography. So GIS, geographical information systems, and it's really plotting things on a map and seeing if that helps us to predict the future in terms of how things will be. Because right now we've been looking at lots of different maps, and you see maps all the time in terms of just seeing relationships across different states, but this doesn't really necessarily tell us anything about what the future might be. And so medical geography aims to do more than just describe. It tries to predict what's going to be happening in the future. And so in that way, it overlaps with epidemiology quite a lot, and epidemiologists use these techniques as part of our field. And so one thing that I've done here is I've looked at the key factors, the key risk factors for coronavirus infection and more critical illness. And so there's a few things that you'll notice here. The first thing that we've talked about previously is age is a strong predictor. So people over the age of 65 are much higher risk than people under the age of 65. One other thing that you might not have known about is wealth. People who are much poorer tend to be much more likely to be infected, largely because they live in houses or apartments where there's typically a lot more people living in that house than in houses among people who are more wealthy, where they live on more closely together and in smaller houses. So there's a difference between socioeconomic status. And then you have these other types of things in terms of the comorbidities, like COPD, asthma, hypertension, diabetes, obesity, and kidney disease, where if you see these examples, there's variation there. Some of the difference between wealth, socioeconomic status might be driven by these comorbidities that are driving it, but there's other things that might be driving it as well. So let me go through just a bunch of different examples in terms of where we are. It's just really interesting. All right, so the first thing, so this is the most recent map of what's the number of SARS-CoV-2 infected people relative. So it's a proportion in the country where the cases are right now. New York and New Jersey, the East Coast, we still have a large volume, but it's decreasing rapidly. So the numbers that we were looking at previously were the rates of increase, but if you start with a small number, then you still end up with a pretty small number, even though the rate might be increasing a lot. Epidemiologically, we need to know where the rates are increasing, because that's how we predict the future, where things are going to be growing. But in terms of where all the cases are, there's still a lot you see in some of these big areas. So what I wanted to do, first I compared where we are as of yesterday compared to where we are or where we were roughly a week ago. There's a little bit of difference, some darkening in some areas here. So this is June 6th, but mostly it's pretty much the same for a week ago, just the big picture, high level picture where most of the cases are. So I'm gonna use this June 6th map to do a lot of comparisons based on the risk factors that I just discussed. So here, what we're looking at is a map on the left of where are people over the age of 65. And the darker it is, the more likely there are people over the age of 65 there. And the lighter it is, the less there are people over the age of 65 as a percentage of the population. So you see a lot of people in Florida who are over the age of 65. You see some people up here. One interesting thing is that despite the risk that we've seen, you'll notice over here on the right, and you'll see over in some other places, it doesn't align very much where the older people are living. And so you see that there's during that first wave, or I don't know if we want to call it a wave, but during the first few months that we've been experiencing this, we've been able to protect a lot of people over the age of 65 in terms of who's getting infected. And so that means the infection fatality rates, this kind of stuff, are less than they would have been if more older people had been infected. And so the worry now going forward is that we might see more people over the age of 65 get infected as the disease spreads to some of these other areas that haven't been hit so hard yet. And so this is something for us to be looking out for. Like, look at Texas. And so there's some areas that you'll see around the country where there's a real risk here. Typically what you see over time is this geographic distribution that changes over time. And so this, if I were to predict the future in terms of where the spread and who's going to be getting hard hit, say over the fall or winter that we're going to be going into, I would predict that there'd be a spread to some of these other areas where there's a higher density of people over the age of 65. Similarly, now to talk about density, here's population density in general. And so you'll notice, of course, on the East Coast, on the West Coast, where some of these big cities are, this overlaps a fair amount with what we've seen in terms of COVID-19 and SARS-CoV-2. And yet, there's some areas that you might expect a little bit more based on the versus what we, actually see over here. And so that means that because we know population density plays a role, just more people living in a confined area, then that means that there's probably some more opportunity here for infection on the, let's say, on the eastern half of the country than what we've seen. We've already seen quite a lot, but you see that there's definitely some areas for more spread just based on population density alone. When you combine age and population density, then interestingly, what you'll notice is that, so the darker, so green is in metropolitan, is in non-metro areas, so more rural areas, but the darker that you go, the more older population is, or the older the population is. So over the age of 65, the percentage, so let's say the darkest green has over 25% of this county is over the age of 65. And because it's green, it designates that it's not a metropolitan area. It's more of a rural area. And so a dark purple or blue or whatever this color is represents that that over 25% of this county is over the age of 65. So this tells us these two things at once, which is useful. And yet when you look at Florida, where this is a really dark area that has more population density than some of these other more rural areas and has more people over the age of 65, what you'll notice is that right now it has not been hit very far. And so there are still a lot of places around the country when you dig in and really start to look at what's going on, that once we start to reopen and let down our guard a little bit, that we will likely see this geographic distribution that we're seeing on the right before which is mostly a residual artifact of the lockdown and who was infected before the lockdown, because that's where the spread is now coming from, versus what it's likely to be going to on the left. Similarly, when you look at living alone versus living with others, I'm going to just go through this one a little bit faster, but you know that the more people living in a household, the more likely they are to spread. That's what we saw in Italy. It's what we saw in a bunch of other places, both in the US and around the world, that the more people living in the household, the more the chance of getting infected. This is life expectancy. It's related to age, but so in terms of places that are blue, the life expectancy is higher. People where the life expectancy is less, There's a variety of reasons that go into that, including the comorbidities that I'm about to go through. But you'll notice that the numbers here, you see some dark areas here, but there's a lot more areas where they could really get a lot more COVID-19 cases over the coming months. I'll just go through some of these a little bit more quickly. So the stroke belt, I don't know if you've heard this term before, is generally considered to be this area over here is the stroke belt. It overlaps a lot with the heart disease belt. And so when you look at other ways of looking at this, this is age 65 and over for death rates. This is age 35 and over. These people are at the highest risk or among the highest risk. There's other risk factors too, but this is a really big risk factor for dying and having critical illness from SARS-CoV-2. When you compare this stroke belt, the heart disease belt, versus where we are, you see, look at this, look at how dark this is over here in terms of how severe it is in some of these places, and yet over here it has not been very hard hit. So this is something you can expect, that there will be this transition, this epidemiologic transition over the coming months, especially as people let their guard down. In terms of insurance, typically people who have insurance are different in a bunch of different ways. It's not, insurance is an indicator. It's not just the insurance itself, but if someone has insurance, they're more likely to go to the doctor more frequently. They're more likely to be tested. People who are uninsured tend to be surrounded by more people who are uninsured in their lives. And so that might increase the risk as well, because if someone is infected, maybe they'll be less likely to be diagnosed, and maybe they'll be less likely to be able to socially isolate themselves because they need to go to their office or need to go to the job in order to get paid. And so the uninsured population could be a indicator of that. And when you look at this, look at Texas and look at Oklahoma, big opportunity there in terms of infection that we might see the spread. Similarly, kidney disease, a lot of kidney disease up here, and you're not seeing it as much in like when you look down in Texas, look down here, you're not seeing as much COVID-19 in these populations yet. So again, this could be where we see some of the epidemiologic transition. Diabetes, diabetes overlaps a lot with the stroke belts, and so again, look at these areas up here where right now there's not a lot of SARS-CoV-2 that's there, and so again, there could be this shift. So these are places where I'm definitely looking out for. Here's COPD, and so again, these are areas that I'm definitely going to be concerned about over the coming months, particularly as we go into fall and winter. There's only a few more. I'm going to go through them quickly. I think this is so fascinating talking about these things. So asthma, as you go up here, so asthma is another risk factor. And you see over here, there's not a lot of SARS-CoV-2. There is some, but relative to what we saw in some of these other areas. This, and again, the primary reason that these areas got hit so hard, so fast, was simply because of travel. People had traveled out of the country. It took us days or weeks to lock down until we realized that it was time and that we needed to lock down. And so this was almost a founder effect in terms of where a lot of these people were living at that point. In addition to the population density, other risk factors, we talked about the case statistic last week in terms of how. But as we now have a more mature development in terms of SARS-CoV-2 around the country, we're going to see this shift to some of these more high-risk places, and that's where we're going to really need to be concerned. Other thing, hypertension is a risk factor. When you compare this map of hypertension to SARS-CoV-2, again, it's not overlapping. I'll just go through some more. This is socioeconomic status. So typically, what you're looking at here is that, so this is distress. So red are more distressed areas, blue as a percentage in the county, and blue is less distressed areas. Again, when you do this comparison, and we do know that socioeconomic status plays a really big, important role with SARS-CoV-2 spread, and among those who are infected, among the severity of the disease and their likelihood of dying. Again, there's not a lot of overlap right now, so there is some, but we can definitely expect that there's going to be a shift, and there's going to be much more infections in these areas. Racial disparities, so there are we've seen over and over again that African Americans, Black Americans are at higher risk. And look, there's a lot of people living in some of these areas that have not been hard hit yet. And so we can expect that as these places let their guard down, we're going to see more severe disease. Similarly, for Latinos who are also demonstrated at higher risk, you see a lot more Latinos living here as a percentage of the population. And again, right now, we don't see a lot of spread there. So that means that there will be an epidemiologic, or almost certainly an epidemiologic transition, and you're going to see more spread in those areas. Just a couple more, and then we can see if there's anything else to talk about. So this is a social vulnerability index. This has a few different things that are involved. The CDC puts this out, and you see this is the lower half of the country generally have a higher vulnerability index and are more at risk. And so you see there's a lot of places in the southern half of the United States that are still are really at risk. And so we're gonna have to be paying attention to. So having shown you all of these different graphs, medical geography I see is so fascinating. It's incorporated into some models in epidemiology. I don't think it's used enough because this is likely telling us what our future is going to be looking like come in the next months when we talk about fall, winter, and the increased spread. The one other thing is that geography can also be used to mislead. And so while I was looking for some of these maps in terms of looking at the predictions, I came across this one website, and this was a politically motivated website. And so they were looking at areas impacted by SARS-CoV-2 versus not. And clearly almost the entire country has been impacted. And it doesn't really inform at all in terms of either where we are or where we're going or anything. And so I can understand that if someone sees a map like this, they could realize, or they could interpret it as saying that SARS-CoV-2 wasn't so bad, that there's not really any increased risk for them, and that if most of the country is already past the worst part of it, we've already had the peak and now we've come down and we've gotten through the worst. If you look at a map like this, then it seems like, yeah, time to reopen. There's nothing going on here, it's all over. And it worries me that this is just another example that there's a distribution of facts, and that some people are getting better information than others. And it goes back to what we were talking about earlier in terms of people's willingness to lock down. So that was the slide over here, this one, that a lot of people just don't think social distancing is necessary. And I think if I were to see a map like what I just showed, where there doesn't seem to be much difference around the country, where it seems like most states have already been impacted and have gotten over it, then I think I too would believe that social distancing wasn't necessary. And so it really requires a leader and strong, consistent leadership that communicates effectively what the real risks are. Because based on on some of these other graphs that I've just shown, there's a lot of risk that's coming. And different parts of the country are at far, far higher risk than other parts as this evolves. And I don't like using the word evolves because the situation is evolving. The virus is not evolving so much. It is a little bit, but not very much. But I'm talking about the situation evolving as the situation develops over the coming months. So this is something that we're going to need to continue to pay attention to.
It's really interesting. Thank you, Glenn. It's really very interesting to look at it through this medical geography lens and really take it apart. So thank you for helping us kind of perhaps look into the future in this kind of way. Do we have time to wrap up with just kind of one last question?
Absolutely.
Sandy Rock asks, can these large demonstrations that we've been seeing over this past week plus help us get to a herd immunity level more quickly? And maybe we'll lead with that. I know we won't see the effects of these demonstrations for, as you say, 2-3 weeks, perhaps. Is that right? So maybe you can talk and kind of wrap up with your thoughts on these demonstrations and the disease.
Yeah, so unfortunately not. The reason is, let me go down. So I'd shown you this graph previously. This is where countries are, just a snapshot of where we are globally, and most countries are listed here. I'm going to go down to the United States real quickly. All right, so the United States, as of a couple of weeks ago, with all of these people that have been infected, that represented around 4% of the United States being infected, only 4%. We don't expect herd immunity until we get between 50 to 80%. It's still unclear because a lot of it depends, or it almost all depends on how quickly it spreads. And because we know that it's spreading differently in different parts of the states, in different states and different parts of the country, there might be different herd immunity levels, or as we approach herd immunity in different levels. Typically, the faster it spreads, the more contagious it is, and the higher the R value, the quicker you hit herd immunity. Rather, the opposite. The herd immunity is larger, so you might get to 80%. So in New York, where we were talking about the R value being around 5 before the lockdown and before any social distancing, before anything, you'd expect a much higher herd immunity. So there in New York, you'd expect around herd immunity not being reached until around 80% of people were infected. Whereas if the number of people, how contagious it is, and the R value is lower, like in some parts of the country, we're looking at 2 or 3, then an R value like that would mean herd immunity could be reached by 50% or so, maybe 55%, a lower number. I'm not sure how this is going to play out because there's so many states adjacent to each other and the R value is changing so much. So right now I'm just saying it's probably between 50 to 80%. The short answer is that we're nowhere near that in the United States yet. So no, it's not going. This is one of the reasons that most epidemiologists are saying that the winter and fall are going to be really hard for us. It's one of the other reasons we're saying it's going to be hard. In addition to the increase in R that's expected when fall and winter comes, and the fact that more people are going to be staying indoors more of the time, one of the other things that we're going to be seeing is the spread of the flu itself. And flu, where people are sneezing and coughing even more, people who are co-infected might then increase their transmission even more than what the normal R value was. So instead of an R being 2 or 3, the way that it was before, if you have concurrent flu at the same time and people are going around and infecting other people, you might have an R that's even higher because flu is actually increasing the transmission of COVID-19, of SARS-CoV-2. The one thing is that we might see, and this is something, unfortunately, that a lot of us are going to be paying attention to, is South America. So when you look at South America, almost across the board, their cases are going straight up. So they were in lockdown. Some of these countries have just given up now, and they're just saying, okay, the economy is at risk, let's just open up. And they are on their way to herd immunity. They're still a long distance off, but when you're looking at some of these cases, so Brazil, for instance, Brazil at this point has roughly the same number of cases per day that the United States does. And they're quickly going to surpass us within the next week or two. And so there's no brakes on it. You see that it slows down a little bit despite their best efforts, but this thing is just going to continue to go up. It's winter there, continue to go up, and so this is almost like a natural experiment. We're going to be looking to South America to see when natural herd immunity is hit, unfortunately. And so we'll know within another 3 months or so, another 4 months, what our fall and winter will look like. And it is what it is. It's really unfortunate. I wish it could be different. We have to remember this is a global pandemic. It's not just something that we're experiencing in the United States. Some countries are not doing well. They're doing even worse than we are. Some countries are doing extremely well. So for instance, many parts of Europe, even Spain that was hit so hard early on, South Korea that was hit early, they were doing so well, then they had a spike. But I mean, now you're talking about 37 new cases per day, which is not a lot over there. It's enough for contact tracing and testing to deal with. France, Germany, their curves are very different than ours. Germany on a typical day at this point only has 450 or so new cases. That's in contrast to, I mean, the United States is a much bigger country. but I mean, we're still looking at over 20,000 cases on average a day. And this was as of a week or two ago. So it's higher. It doesn't include the more recent data. A lot of countries are doing really well. The United States is not one of them. South America is not doing well, is what it is. So we're nowhere near herd immunity.
Okay. Well, thank you, Glenn, and thank you to everybody for joining us today. Just a reminder that next week we'll be meeting on Sunday at 7 p.m. rather than at 3 p.m. And as always, if you have questions, it's really helpful if you send them to me or to Glenn during the week so that Glenn can incorporate them into his presentation. And you have any last thoughts you'd like to leave us with today, Glenn?
I mean, I've been talking about death and destruction all afternoon. I mean, there definitely are some great things that are happening. We're seeing some new results with the monoclonal antibodies, some of these treatments. We're seeing a lot of vaccine studies that are being pushed forward. So there is a lot of hope. Even by fall, winter, we could start seeing some really good results. And the drugs are now being manufactured concurrently with the studies. So if the studies turn out to be good, then we have so many samples and units available that we could already be distributing it in early winter. So this is really good news. So it's going to be a rough another few months. Summer is probably going to be a slow burn. We do expect a lot more than we would have hoped for. In fact, it could be the case that the number of deaths could easily double, like what I've been saying before the end of the summer. But despite that, we have all of these good trials that are going on, and I just because of the number of different and diverse trials that are going on, I have high confidence that at least some of them are going to be successful. So that's a good parting note.
That is absolutely a great parting note. And we will look forward to hearing more about that and all these other topics when we see you again next week.
Great.
Okay,
Oh, and
thank
again,
you.
just one last reminder, next week, 7 p.m. next week, not the same time because it's summer hours. We want to enjoy the day when it's so bright and beautiful outside. 7 o'clock going forward on Sundays.
Be safe, be well, everybody, and don't forget to wear your mask and stay 10 feet apart.
Thanks, everyone. Bye-bye.
Bye.